GnRH analogs are acting directly on the pituitary. So they cause a pseudo menopause kind of state, that is a hypogonadic state. So, and this will reduce in the size, decrease the size of the fibroids and shrink them. So they have been, they are ideally used for large size fibroids when they have to shrink them before going for surgery. But nowadays, there have been studies which have shown that using them preoperatively will cause more problems, as the planes between the myometrium and the fibroid have been decreased. Next is selective progesterone receptor modulators. Selective progesterone receptor modulators such as mifepristone and ulipristol, they have various actions. So they act on the fibroids, decreasing their size. They act on the endometrium, causing changes in the tissue called as progesterone receptor modulator associated endometrial changes. And they also act on the pituitary. The next option, which we do have in a medical management, is Levonorgestrel-releasing intrauterine device. So it's also called as Mirena. Mirena is an intrauterine device which is kept inside the woman. It contains 52 mg of levonorgestrel, and it works for 5 years. And on a daily basis, 20 micrograms of the hormone is released. It does have a benefit of acting locally and not going into the systemic circulation. And it also is long acting, and it also works as a contraceptive. So it would be an ideal choice to give in women who are in their early 30s or mid 30s. So it is also a very good option for women who are not suitable to take hormonal treatments orally, such as women who have a history of clot formation like DVT, or if women who have liver disorders or gallbladder disorders, or women who are smokers, or people who are 35 to 40 years old. This would be a better choice in the treatment modalities. Next, coming to the surgical management. Surgical management, there we have only removing of the fibroid, which is myomectomy, or removing of the entire uterus. That is the definitive management, which is hysterectomy. So fibroid, only removing the fibroid is opted for women who have a desire to go for future pregnancies and all, because we have to preserve the uterus. Whereas hysterectomy is a definitive treatment. So there are different kinds of surgeries which can be offered to the woman, which is open surgery. And this is more suitable for fibroids which are extremely big. Laparoscopic and robotic surgeries. These are minimally invasive procedures which have less post-operative recovery time and less blood loss and better cosmetic appearance for the woman also. So, and it is also good with patients who have previous surgeries like a previous myomectomy or a previous cesarean. So the adhesions and all can be better tackled during these procedures. Hysteroscopic myomectomy is another kind of surgery which is performed for women who have only submucosal fibroids, and that too the submucosal fibroids which are more pedunculated, which have less intramural involvement. So this would be a better option for women who are looking for the future fertility. Next, coming to non-invasive procedures. Non-invasive procedures are recommended for women who want to avoid surgery or who are not fit for surgery. So uterine artery embolization is a very common procedure which involves sending a catheter through the femoral artery, and it goes up till the uterine artery. And over there, we block the blood supply to the fibroid, causing the fibroid to devascularize and shrink in size. But there are different school of thoughts regarding how the uterine artery embolization would affect the future fertility. Few of them suggest that the future fertility is not affected, whereas few of them say that the entire endometrial devascularization has also happened. So the woman getting fertile in the future would also be difficult. As it is a newer modality, still more research has to be done through it to get a definitive opinion regarding the use of uterine artery embolization to preserve the uterus for fertility. So, but it can be used for women who just want to avoid surgery and who are not fit for surgery. The other non-invasive procedure is MRI-guided focused ultrasound. So this uses high-frequency sound waves, the ultrasound waves, to destroy the fibroids. So this is a brief flowchart on how we can categorize the patients. depending on what symptoms they have, what age group they have, and what kind of treatment we would be going for. So if it is asymptomatic, just follow up. If it's symptomatic within the reproductive age group, and the patient wishes to preserve fertility, either medical management or a myomectomy. And if the patient already has completed her family but wants to preserve the uterus, she can go for a Mirena insertion, or she can go for uterine artery embolization or a myomectomy. Or if the patient has already completed her family, she is above 40, does not want to preserve her fertility or uterus, and the size of the fibroid is more, a direct surgical treatment can be focused for. So there are complications associated with any procedure which we do. In the surgical management, we do have complications such as bleeding, infection, and damage to the surrounding organs, such as the bowel, bladder, and the ureter. The patient should be counseled regarding the complications associated with both medical and surgical complications. And she should also be counseled regarding the recurrence of fibroids. So how to follow up later.